Well, hello there, wonderful fundamental students. This is Miss Gray with another fine lecture on one of the principles of the fundamentals of nursing. We're still talking about the nursing process. And today's lecture is on planning. But before I go into planning, I want to make sure I hit a couple of points that I did not really reinforce a lot in the lecture that are from your book that are important regarding the nursing process. Regarding assessment, I know we spend a lot of time, all our times, focusing on assessment and what illnesses or problems the patient may have. But equally important, and this is probably on the test, equally important is understanding what strength the patient has. So when we're assessing, though we're making our care plan related to the problems, we need to understand their strength and abilities so that we can have the appropriate interventions. So, for example, if a patient has a stroke and they have weakness on the right side, but they're left-handed, that's good. Because even though they have the right-sided weakness, they won't have to do so much adjustment to right and feed themselves because they were already left-handed. That's a strength. A patient who is hard of hearing, but there's still an 80-year-old patient who is hard of hearing but is still alert and oriented, the fact that they are alert and oriented is a strength or benefit because you can still communicate with them by writing or and get clarity, or with the story by writing, or even with a hearing aid or an amplifier. So we want to know, or if we have a patient who is hospitalized and they have family, that having family to support them when they are discharged is a benefit. A patient who does not have family, well, then we'll have to have other interventions to get them discharged to a safe environment. So I definitely want to clarify for you that assessment is about obtaining data, one, about the patient's strengths, and two, about the patient's weaknesses. That's important to remember. Also, as related to care plans have to be individualized and specific to the patient. That's very important. Care plans must be individualized and specific to the patient. What I mean by that is this: you could have a assignment of 6 patients, of which 3 are diabetics. Those 3 diabetics are going to have some similarities in their care plan because of the illness, but there should be some individualized planning. They're not going to understand things all the same way. Their medication regimen is not going to be all the same. The frequency of their blood sugars is not going to be the same. So those kind of nuances speak to the individuality of the care plan. So we do not have a one-size-fits-all kind of care plan. You're looking at your patients holistically. Remember, we're looking at the whole person, body, mind, and spirit, and we're developing an individualized care plan for that specific patient, even though we might have some similar principles in the care plan based on the disease process. So having an individualized care plan is an important concept and is testable. Want to make sure, I know I didn't speak to this in the last lecture, that you understand when we're talking about interventions in our planning that there are 2 kinds of interventions, nursing interventions. There are dependent interventions and there are independent interventions. Dependent nursing interventions are those things that have to be prescribed or written as an order by the doctor. So dependent interventions are, a nurse cannot do them without a doctor's order. Independent nursing interventions are those things, actions, nursing actions that fall under the nurse's scope of practice, such as checking a blood pressure or a temperature. So I just wanted to point out those things that I think I didn't cover in as much depth either in class or on the last lecture. Please write down any questions if you have them. So now we're going to go forward with planning. We've talked about the nursing process, and now we're looking at the planning. So we've covered assessment, nursing diagnosis, and now we are talking about planning. Now, planning, as we recall, it involves determining problems and prioritizing them, and then formulating the goals and desired outcomes, which we found in your Sparks and Taylor book, as well as select nursing interventions. Now, the interventions that you write must be specific to your patient. We're expecting that when it comes to your care plan. So if your patient is bedridden and contracted because of inability, we don't expect you to it would not be appropriate to have an intervention to ambulate that person because they're not ambulatory. So your interventions must be real and have the potential of actually being performed with your patient. So your planning begins with your patient, with your patient contact, and it is important that you build that relationship. And again, when we're talking about dealing with your working with your patient, we're bringing in the concepts of communication. So we're always thinking about everything that we do builds upon something else that we have done. So when we're talking about planning and patient contact, we still want to utilize the concept of therapeutic communication and being friendly, being approachable. Also, planning is not just done by the nurse. Your physical therapist, your speech therapist, other providers are involved in the care plan. In many facilities, there is a interdisciplinary care plan that all of the members of the team write on. In other facilities, each discipline has their very own care plan, and they come together in a conference to kind of put those pieces together. But the idea is that there is that care planning is a team process. So again, we might have our initial planning that's done when we first meet the patient, and it should be initiated right after the assessment. We don't want to delay care. And the reason you want to initiate your plan right away, again, is you don't want to delay care. You don't want to do that because we are going to be licensed professionals. So you don't want to delay care. And then your planning is ongoing. You work and it's done by all the nurses who are assigned to the patient. So if I work on the day shift and I admit the patient, I might initiate his care plan. But each nurse that follows me on any shift or any day should be observing the patient and gathering data and making changes in the patient's care plan as necessary. So it's ongoing. Again, just like the nursing process, every aspect of it is ongoing and dynamic. A very big part of patient care is discharge planning. It's the process of making sure the patient's going to have their needs met when they get home. And it is illegal. It is illegal. It is illegal to discharge a patient from a facility into an unsafe environment. So if you, the nurse, are aware that the patient has dementia and no caregivers, and you know they cannot care for themselves, you cannot send them home by themselves. It would be unsafe. So the nurse, the team are responsible for making sure that that patient has a safe discharge. Because if something happens to that patient, the hospital is responsible. So that's why it's good to know your patients and get a sense of what their situation is going to be so you can begin to plan ahead. And discharge begins on the day of admission. It begins on the day of admission because admissions are so short, hospital stays are so short, but it just takes time to gather, all the resources and get more members on the team based on the patient's needs. So discharge planning begins the day of admission. And then you're going to, there are different kinds of care plans, and this is just good information. The key, we know that some are written and some are computerized. Some facilities have standardized care plans, but you are still held accountable by Joint Commission to individualize them. So there's really, they might have an electronic format, but it must have some capability for you to make it specific to the patient and design it that way. So we want to have individualized care plans. Joint Commission, this is really the gold standard for all of your accrediting bodies. It's what we really care about, the individualized care plan, because our accrediting bodies expect it of us and our patients deserve it. So I have standardized. Now, the care plans can be standardized, but they might be standardized in format, but you, the nurse, have to individualize it. What comes down to protocols are those things that your facility might allow you to initiate standing orders based on the patient's situation. For example, when I was at Aurora, all patients that were admitted to the cardiac unit were to get an IV, at least a 20 gauge. That's the size of the IV. Because of that standing protocol, I didn't have to call the doctor and ask to insert an IV. They had protocols. If a patient had a particular lab value, white count, or looked septic, then there was a protocol I could follow without having to call the doctor. If a patient has chest pain and they code, I didn't have to ask to get an order for nitroglycerin. There was a standing order or protocol for that. So those protocols are facility specific, but you should know that they exist. And then this is just review. Standards of care are directed by our nursing organizations, and they describe what it is a nurse should do. They describe the achievable or ideal in terms of planning. When there are the standards that a nurse should maintain are set by our ANA. When it comes to planning and the nursing process, it's expected of you to create a plan that is achievable and provides the best care for your patient. you're not going to say that a patient who has a right knee below the knee amputation is going to walk without assistance the day after surgery. That's neither realistic nor is it achievable. So your interventions you're accountable for. You don't want to have a patient with chest pain and you don't offer intervention to put them on telemetry and give them the appropriate medication. That would be following standards. So even your interventions, there's a standard of care the public expects that has been set for you by our professional organizations. And so even that's why that NANDA book is important, because it sets the standard. It's a tool that you can use to validate that you are following appropriate standards. And your planning, your plans are written from the perspective of your responsibility. We're not writing for the plan for the physician for their actions, to direct their actions. They're written from the nurse's perspective. Your standardized care plans, again, they're guidelines. They still have to be made specific to the patient's needs. Again, the protocols just describe specific actions that should be provided, like all patients that are when they have swallowing difficulties, they should be allowed to sit upright for 30 minutes after meals and not allowed to lay down so that they don't aspirate. That might be a protocol. Might be a protocol that patients with tube feedings have to be rounded on every 30 minutes. There are protocols for a particular group of people. Protocols may include physician orders and nursing interventions. Let's see. And then we have our standards of care. Oh, I lost my page. And then we have policies and procedures that we must follow. And a very common aspect of care are your standing orders. Now, standing orders can be in our plan of care. The physician may have standing orders. So you may have a patient, like our patient that we worked with that had pneumonia in class. If a patient has pneumonia, the doctor might say, well, pull out my standing orders for pneumonia. And those standing orders might include any patient that has pneumonia to get a IV, to get an IV fluids of normal saline at 150 cc's an hour for 4 hours, to get Tylenol every 4 hours, to be put on special antibiotics, every 12 hours. So the standing orders can be physician specific or they can be facility specific. Generally, with standing orders, you as the nurse can activate them with the doctor's permission and they can come and sign them later. But with the electronic records now, a lot of times the physicians they generally will be activating it from their phones or their electronic tablets or other devices. And the standing orders give the nurse, the authority to carry out specific actions under certain circumstances. And a key to remember here is, when in doubt, ask. Ask one of your co-workers or call the physician before carrying out an order that you are not definitely sure you have the legal right to perform. And again, individualization of standardized care plans. These are just various principles. The key is it must be specific to the patient, and they must have be both pre-authored and have pre-authored and nurse created sections. That means there must be some aspect of the care plan, if it's standardized, that the nurse has to create or add or supplement. Um, Standardized care plans are predictable, and again, generally they exist, but they must be individualized. Individual plans for unusual problems. Um, Sometimes facilities may have like a blank care plan that you can use for problems that are so unusual. There is not a standardized plan for you to work with to individualize for your patient. So you can have an individualized plan, but it must be individual. You may have a standardized plan. You may have a standardized plan, but it must be individualized for your patient. Now, nursing care plans can take many formats. Again, written, concept maps, computerized. You just should be aware that there are many kinds. This is an example of a pathophysiology concept map, and it's a larger view of what you were or will be asked to do regarding pneumonia or some other illness. This particular plan looks at the types of pneumonia, the diagnoses, the treatment, the manifestations, and other types of things you should know about the illness. Again, things you'll think about and gather data about as you are assessing your patient. These are a few rules that about nursing plans of care. As you might recall, all care plans must be dated and signed. They must have a heading. You must use approved medical symbols and keywords. They must be patient specific. You can use your NANDA to make sure that you are following proper procedures in the layout of your care plan, and you need to have a patient-specific care plan, having that individualized care. When we're doing care plans, again, we want to not just think about our care from the patient's care from a nursing point of view. We want to incorporate other disciplines. We want to make sure that we understand that it's dynamic, that it includes ongoing assessment, and that we want to include discharge planning. When you're planning, you always want to set priorities, set goals, and you must do that in collaboration. You should with the patient, and individualize the interventions. It's important that you set priorities, establish goals, select appropriate and specific nursing interventions, and make sure that those interventions are individualized. Even if the goals might be the same for two patients, their interventions are going to be different. No two patients have the same interventions entirely. Setting priorities, again, you want to establish a sequence of addressing your nursing diagnoses and interventions. When you're setting priorities, these are things for your patient and your goals. These are things you want to think about: the patient's health values and beliefs, their priorities, the resources available to the patient. because everything that you might have available to care for them in your facility they may not have at home. And then what does the doctor want to do? And what is the urgency of the problem? Let's see. So when we're planning, we're setting goals, and your goals are broad statements about the patient status and the desired outcomes that you want to have. And once you set a goal, you have to provide the interventions to reach the goal, but then you have to reevaluate and reassess to determine if your desired outcomes are being met. And this is an example of an outcome, or deriving an outcome for nursing diagnosis. Now, when it comes to the interventions, nursing interventions and activities are actions the nurse performs to achieve the goals, and they focus on reducing the reason, the etiology for the problem. So your nursing actions are done to reduce the etiology. So for example, if my patient is having a potential for skin breakdown due to immobility, I'm going to have as an intervention to turn that patient or reposition that patient every 2 hours. By doing that, I am performing nursing activities to reduce the etiology for that bad skin integrity, the immobility. They're immobile, I'm turning them. So I'm reducing the etiology for the problem. Nursing interventions also treat signs and symptoms and defining characteristics, such as giving them medication as ordered to reduce the blood pressure or reduce the address the dizziness. Interventions for risk-related nursing diagnosis should focus on reducing the patient's risk for that problem. For example, if a patient has an unsteady gait and they're at risk for falls, then I'm going to want to make sure he has a bed alarm, a chair alarm, that we have a gait belt on him, that we round on him or check on him or her, frequently every 30 minutes or more. So thereby doing those things, I'm reducing the risk for them to fall and have injury. Just back again, interventions are also related to independent and dependent interventions. Independent are those things you're licensed to do, and dependent are those the physician must prescribe. There are also collaborative interventions that you carry out along with your other members of the interdisciplinary team. And the criteria for choosing appropriate interventions are to be safe, achievable, and are congruent with the patient's beliefs and other therapies. So I'm not going to ask an 80-year-old to run 5 miles with pneumonia. I'm not going to expect a patient with arthritis who has chronic pain to necessarily be pain free. I might want them to have a pain level that's manageable for them to maintain their activities of daily living and be able to go back into their homes. And you also should have your interventions based on your knowledge and expertise, and they always must fall into established standards of nursing care. We're always held to that. And that's why you have the NANDA book, your Sparks and Taylor, to help you identify appropriate interventions. Again, when you're writing a care plan, these are keys that you must have. You must have the date and time when it was written. You'll want to have your conditions and modifiers, pieces that we have gone over in class, and that we will again with our care plans. And then don't forget that nurses relationship of nurse, your relationship to in planning is you want to observe, you want to prevent. You have different kinds of you have different kinds of interventions that you can perform. You have interventions in which you're observing the patient. You're going to round on them or check on them every hour. You have prevention interventions. A patient's going to be ambulated every 2 weeks or every 2 hours. Every 2 hours. Or you're going to turn the patient every 2 hours so that they don't get bed sores. Or you might have treatments. You might have to give them a breathing treatment every 2 hours or every 4 hours. Or you have health promotion interventions related to nursing teaching. So there are different kinds of interventions. These are the kinds or the categories of interventions that you can use for, or you'll get from your book related to the care of your patient. So in summary, what I'd like you to know about your key knowledge points related to planning are that your planning, you must prioritize and formulate goals and outcomes and nursing interventions that are based upon a specific standard. That those standards are in what your NANDA book supports. Care plans may be standardized, but you still must individualize them to the specific patient. When you are setting goals, you should try to do them or set them in collaboration with your patient. Your goals must be goals that are achievable as much as possible with your patient, for your patient. And your interventions also must be achievable and appropriate to the status of your patient. Well, that's all for planning. Make it a great day.